Okay, good morning, everyone. Thanks for joining us again this week. A little slow to gather this morning, but I think we better get started because I have 8:03, and this I think is probably our ninth session in this series. So I have control of the slides. Let me advance them here. Again, reminders not to disclose any private health information during your case discussions. Here is the usual information about contacts. Usual information about cardio. And today I'll be facilitating as usual. Kathleen will be presenting, and our lead discussants this morning will be Kathleen and Karen. We have two very interesting cases, very similar to each other, interestingly enough, from Kara and Robbie. And our usual disclosures, I don't believe there were any changes from last week. And Kathleen, take it away when you're ready.
Great, thank you. We have three objectives for this didactic session. We're going to highlight and describe a few barriers that are specific to individuals with diabetes. We're going to discuss some alternatives to the newer medications in terms of patients who cannot afford them, and also describe the use of CGM and some of the barriers and how to use effective strategies to promote uptake, particularly among minority communities. So as we are all aware, I skipped the slide. As we are all aware, A1C targets can be very difficult to achieve. If we consider even a more individualized goal range, only about 3/4 of individuals in the US achieve that A1C of 8%, and only about half achieve an A1C of less than 7%. And this is more concerning, especially in younger individuals, as diabetes is diagnosed at an earlier age. We can see here on the panel on the right that a little over half of individuals achieve that A1C less than 7%. And if you look at in people who are requiring insulin, the numbers are even lower. And so the numbers that are achieving these targets are lower than that achieved for the blood pressure targets of 140 under 90, but still there's room to go in all spheres. And so the barriers, there are many, and we've really already discussed most of these, I think, in previous sessions, but they're worth bearing repeating. I think some of the barriers that are really specific to diabetes in particular is that we tend to have a sort of a wait and see approach, a tolerance, and sort of an ease of trying to only rely upon, maybe, changing your diet or things like that. There are limits to availability of diabetes self-management, education, support, and medical nutritional therapies. And there are a lot of fear of some of the side effects. There's just a lot of garbage out on the internet, as we all well know, and it's very difficult for patients to sort through those. And then finally, as patients get more and more therapies added on, and not just for diabetes, but for blood pressure, cholesterol, the complexity becomes very difficult to manage. On individual population levels, there can be a lot of mistrust, and there can be limited support in being able to take care of all of the things that need to be done in an individual who has diabetes. And then there are these barriers that we've discussed already on the part of our providers. In particular, when you're taking care of a person with diabetes, we're needing to use a lot of motivational interviewing techniques and shared decision making, and going through different treatment options and building that trust with the patient does take time. There is also some concern about complexity, side effects, just as patients have. And then finally, on the part of the systems, there are a number of barriers. In particular, the ones that I think are probably most important our lack of infrastructure to support population health initiatives and team-based approaches. On the part of many payers, there's a lack of transparency in formularies and a lot of barriers there. So and I won't go through all of these, but the social determinants of health are part of many of these barriers, and you can see many of these cross over into persons with diabetes in a number of different ways. And there's a really nice scientific statement here. There's also another scientific statement that was released by the Endocrine Society, taking a look at social determinants of health. Now, how do you overcome these sort of barriers? Well, I think that's a really easy thing to say, but really not very easy to implement. We use these terms that Gotha mentioned, like therapeutic inertia, but it's a lot more complicated than that, and really more narrowly defined, I think, than is always appreciated in the literature. But this is, for what it's worth, a statement from the American Diabetes Association and sort of their efforts to recognize the need to provide team-based care, to implement technologies which we know are effective, and to address all of those social determinants of health as part of any health encounter. So in terms of the biggest one of the biggest barriers, which is financial barriers, this can be somewhat challenging to navigate. Thankfully, in our own Medicaid population, it's pretty straightforward, and they don't have to pay for the vast majority of their medications. But there are a number of health plans where there are high copays and deductibles, or some of these spend downs, individuals who don't have the opportunity to use some of the programs, medication assistance programs, if they don't have citizenship or what have you. It can be, really a challenge. So this is just a skeleton, bird's eye view of the ADA guidelines, and just kind of as a refresher, everything, of course, is based upon lifestyle changes, self-management, education, and support, and evaluating those social determinants of health. But then beyond that, we're looking at major comorbidities, and not just going straight to metformin anymore. So if they have cardiovascular disease, heart failure, or kidney, any kind of kidney disease these days, we're going towards the GLP-1 or SGLT2 inhibitor, and potentially adding another agent if needed, if the A1C is above target. And if not, then again, we're looking at agents that have the efficacy to achieve and maintain not only A1C or glycemia, but also weight management goals. And so this is a change in the last year, and really, instead of being A1C focused, focusing on recognizing that diabetes is a chronic progressive disease, and weight management is a key component of maintaining A1C at goal. So as a barrier, cost is really, as you might imagine, very prevalent. About half of adults who have diabetes report some financial distress, and a quarter of individuals who are prescribed insulin will report rationing it due to that cost. And in terms of chronic illnesses, about 2/3 of people who have cross-related adherence actually don't even share this with your provider. So I think, as a whole, we have to assume that patients are doing this, and try to kind of help them work through it as best as possible. And these are just a list of several of the low cost options for medications. And we tend not to use them as much because they're not as effective with A1C reductions and weight, but in the right settings, they are still effective, and they still remain a component of therapy. So just a couple of caveats here. I won't go through all of these details, but I wanted to provide a little bit of insight for you for your reference. The sulfonylureas these are tending to be, less favored, although they're very effective, and we tend to prefer them for patients with monogenic diabetes. So that's the diabetes that's inherited as a autosomal dominant trait. And but the main drawback is that they have a shorter durability than almost any other therapy that we have. So they work well for a few years and then they just quit. So that's something that you have to recognize and make sure that the patients are aware of that. Glynides, probably similar, but they are more flexible, because if you have a patient who's not eating regular meals or just kind of eats one big meal a day, there's less risk of hypoglycemia. And the trade-off, however, though, is that complexity of having to take it with each meal. Now, thiazolidinediones, I think, really went through a really rough patch, and there's increasing data in more recent years that they can have some cardiovascular benefit. They also probably have some benefit on metabolic liver disease. They do have a much longer durability compared to metformin or sulfonylureas. So that's one benefit. On the flip side, we all know some of their risks in terms of fluid overload. They don't actually cause cardiac damage or heart failure, but they unmask it because of that fluid retention and sodium retention issue. And then there's a fracture risk in postmenopausal women. Alpha glucosidase inhibitors are great for postprandial control, but tolerability and complexity issues also a concern. Okay, so as we think about these low-cost drugs, should we just, should we use them or not? Well, I would just bring us back to the UK-PDS study, which is very old, but essentially they had a couple of arms. They randomized patients to sulfonylurea or insulin versus conventional therapy, and that achieved an A1C reduction of only about 0.6%, but 8.5 versus 7.9%, or metformin versus conventional therapy, which again is just any therapy, so they're not symptomatic. And they achieved about a 0.5% reduction in A1C. And at the end of the intervention period, they did demonstrate reductions in microvascular complications. And then fast forward, once they've finished the study and they continued to follow them long term, about 10 years later, they were able to identify reductions in myocardial infarction and mortality. So there definitely is benefit, and there's benefit when starting therapy early. So these were recently diagnosed patients. Now, if you look at larger epidemiologic type of analyses, yes, compared to other therapies, metformin and pioglitazone, which I've highlighted for you here, have some cardiovascular benefit. The insulin secretagogues, again, this is compared to all comparators, is relatively higher. And then in terms of mortality, you see that same kind of pattern for the insulin secretagogues. And moving on to insulin, so we had a small win this past year in our Medicare patients. Now they have a $35 cap per month as of July 1 this year, and there are some other caps that are going to be put in place. For patients who don't have Medicare, there's still some limited options. There are programs like the Lilly insulins for $35 a month. So that's where you can get the basal and prandial insulin analogs. Other companies do have these programs as well. There might be a little bit higher copays for those. Walmart has the cheapest insulin, so you can see some of those priced out there. The 70/30 insulin, the Novolin, which is NPH and regular premix, is your cheapest option, so $25 a vial. But then you have to consider all the other costs of strips and supplies and lancets if an individual doesn't qualify for CGM. Thankfully, Medicare covers CGM pretty well. It can be cumbersome, but you shouldn't have too much costs there. And then there are a couple of reminders on the use of these older insulins. Again, they can be effective, but just remembering that NPH in the green line there peaks in the middle of the day. And so you're either going to have a small lunch to cover that, or you could use an extra injection. Then the evening dose, you give it right before supper. It can peak in the middle of the night, so sometimes you need an evening snack. And regular insulin is best administered 30 minutes before meal, which is a real tough chore for many patients. But trying to get to that physiologic kind of regimen, that's really what you would need to do. So there are, as it turns out, a number of studies demonstrating a fair number of disparities in CGM use. And these were originally and primarily in patients with type 1 diabetes, where there's by far the most data out there. This is data from the Type 1 Diabetes Exchange. And it's actually a couple years old, and it's, even a couple years old is an eternity when it comes to diabetes technology. But you can see in this data set with 11,000 patients, CGM is associated with these really nice A1C reductions of over a percentage, just again using a device and not extra medicine, reductions in DKA and severe hypoglycemic events. So these are really useful technologies. Unfortunately, in this study, and we've seen in other studies, there's incredible inequities across a number of different socioeconomic indicators. And here we've shown race is one of those. And even if you persist, even if after you adjust for insurance, so it used to be we were fairly, perhaps somewhat judgmental in who should have these devices. As this study indicated, I put this quote here because I thought it was very powerful here, in that most had not been offered it by their providers. And so this was just published, but I think the landscape has changed a lot in the last year as payers have come to understand this a bit more. But when you put barriers in place for CGM, you get inequities. And so this is one example of CGM that was liberally funded in Colorado Medicaid. And so you see these nice reductions in A1C after they, kind of relinquished all those barriers, and particularly in type 2 diabetes, not quite as much in type 1, which is more complicated. But then if you look at the bottom right panel here, A1C reductions are very similar among, non-Hispanic whites, Hispanic, and non-Hispanic Blacks. And there are a number of kind of, sort of predictors of use, things that we think probably are pretty intuitive if a patient's on insulin has a high A1C. And then continued use, though, those individuals with the highest A1Cs are going to continue using it. And maybe some of the lower ones may not, and maybe they can go on to a kind of an intermittent use. And so how you can address these inequities, I mean, the first one by far, I think, is just giving it to them without those barriers, and giving it to them at no cost. This is just kind of a nice summary from ACDCES in terms of how do you optimize devices for patients. I think this is a little bit less necessary in the current days as technology improves and it gets smaller and becomes more flexible and adaptable. But one of the big things I would call out is just device compatibility. There's nothing worse than ordering a device for a patient and then they want to use their phone with it and it's just not compatible. So I would suggest that as one thing to consider, the location of wear of the particular device. And we have a great couple of resources on cardio that kind of spells out some of the difference between all of these devices. But there might be different types of configurations that patients might be interested in, such as sharing their data with others and what kinds of reminders they get. And then the education here is key. So in terms of getting them on it, but keeping them on it is really important. And what expectations, when they need to check a blood sugar, how to troubleshoot, what kind of goal setting they might implement, and then actually providing feedback. So just giving them a device is only part of the solution. Actually, patients do much better when they're given feedback, and ideally it would be real-time feedback. So this is just one last example that I'll leave you with. This is the example of a practice transformation at a safety net hospital. And so this was started actually pre-pandemic, but you can see some of the little landmarks during the pandemic as well. So this was in fact a type 1 specialty clinic, but I think some things that can be learned from it. They started off with having sort of these regular meetings to identify the gaps. They implemented a social needs coordinator. I think that could be a nurse, that could be a number of different things. And they implemented telemedicine, which was more out of necessity, but they also used the device companies themselves to provide some samples and implementing device trials. And they actually had the manufacturers train the staff. And I think that can be valuable if you don't have staff already available to do that. And then all of the staff are trained or cross-trained in how to download reports and link patients to their clinic accounts. Again, taking advantage of the technology and being able to provide that population health. And then they worked on more of the prescribers and implementing workflows, especially for durable medical equipment needs, and working with, one or two different device or DME companies, I think can be useful, because then you can have that feedback and that communication going both ways. And then they implemented provider bias training. So all of this, and then you can see as the CGM prescription rates went up. And CGM is standard of care for type 1 diabetes, and it should be for most people who are on multiple shots and probably even a single shot of insulin a day. So they still had some room to go. And then these are the results. So their CGM prescription rates by race went up in all of the categories shown here. They doubled in non-Hispanic white, but in the Hispanic populations and Black populations, those numbers tripled or more. So that I think is a win and a nice example of how you might implement this. And these are just specific recommendations to promote CGM uptake. So again, these population-based approaches can be helpful to identify individuals, and tailored education and support are critical. Developing virtual care models. There's all kinds of virtual care models that can be run by pharmacists and also diabetes educators that can even make these sustainable. And then incorporating that into the virtual care. And I will stop there. Thank you.
All right. Thank you, Kathleen. Great presentation. Any questions for Kathleen before we move on?
This is Karen. I have some Medicare patients that would really benefit from CGM, and they just don't want to have to pay the copay. So I think it's a shame that that's still an issue. People with fixed incomes, they just have to choose whether they're going to do that or not. So I'm hoping at some point that the copays will go away for Medicare recipients.
Yeah, I agree. Yeah, they're covered, but they still can be a copay.
How much is the copay roughly? Karen or Kathleen, do you know?
I'm not actually sure, but it's always going to be like, what, 20% of the...
Oh, yeah, that's a lot. Okay.
Yeah, so I think you can get a Freestyle Libre out of pocket. I want to say it's like $75 a month.
$74.99.
Yeah.
Oh, out of pocket. Okay, so it's still it's like $20-$30 a month then we're asking them to pay.
This is another weekly reminder. You can view all past and present echo recordings on the Cardio website. Next slide. We would like to invite you to our spring 2024 webinar about fatty liver disease. You can register at the Cardio website. There's CME credit at no cost. Next slide. A reminder that the post-clinic survey should be in your inbox by now. Please complete that by tomorrow evening. I also wanted to remind everyone that due to the holiday next week, we will not be having an echo clinic, so we will see you again on the 30th. And then just email me with any questions.
All right, thank you. And I just saw that Kathleen posted those the link to the resources from the Cardio website, so please take a look at that. All right, thanks everyone. Have a wonderful Thanksgiving, and we'll see you in a couple of weeks. Bye-bye.